Welcome to the Deep Dive. We're here to unpack complex medical realities, bringing you the insights that, well, truly matter in clinical practice. Today, we're tackling a pediatric orthopedic challenge. It's common, yet it remains a significant diagnostic pitfall, and one that carries really profound long-term implications if it's missed. Picture this. A 13-year-old, active, seemingly healthy, suddenly starts complaining of this nagging, vague pain around their knee after football practice. Now, what might initially look like a minor sprain, maybe just growing pains, could actually be the subtle early sign of slipped capital femoral epiphysis, or SCFE. It's a condition that predominantly hits adolescents, and the diagnostic and management hurdles it presents really demand sharp awareness from all of us in the medical field. To guide us through this really critical discussion, we are incredibly fortunate to have Professor Mo Imam with us. Your extensive experience in orthopedic surgery, particularly in pediatrics, offers such an invaluable perspective as we start this deep dive. We're aiming for a vital update on current understanding and best practice for SCFE.
Thank you for having me. And you've really hit on a crucial point right at the start there. SCFE, or as it's often called here in the UK, SCFE, slipped upper femoral epiphysis. It genuinely is the most prevalent hip disorder we see in adolescents. And your example, the footballer with knee pain, perfectly illustrates why we just cannot overstate the importance of early detection. It's a condition where vigilance, a high index of suspicion, can truly make all the difference to a young person's future mobility and their long-term hip health.
Absolutely. And that vigilance, it has to start with a precise grasp of what's actually going on. Professor, when we talk about SCFE, the name itself can be a bit misleading, can't it? We say slipped epiphysis, but the mechanics are, well, more nuanced. Could you clarify for us what's really happening inside the hip joint and why that distinction actually matters for how we understand it clinically?
That's an excellent point to begin with. Yes, while we call it slipped capital femoral epiphysis, suggesting the ball part of the joint, the epiphysis, slips, what's actually happening mechanically is, well, the opposite. It's the femoral neck and shaft, the metaphysis, that displaces. It moves anteriorly and superiorly relative to the epiphysis. The epiphysis itself effectively stays put, anchored in the acetabulum. So you could picture the ice cream ball staying in the cup while the cone shifts away from underneath it. This slip typically happens in a backward and downward direction, right at the weakest point, the growth plate. Understanding this distinction is really vital for interpreting the x-rays correctly and understanding the deformity that results. And as you said, SUA is the common term here.
That's a great clarification. That ice cream cone analogy really helps visualize it. So to really get our heads around this, let's set the anatomical scene. Could you elaborate on the specific parts of the hip involved and crucially the pivotal role of that growth plate, especially in adolescents?
Of course. So the hip fundamentally is a ball and socket joint, built for a wide range of movement. The socket is the acetabulum, part of the pelvic bone. The ball is the femoral head, the epiphysis right at the top end of the thigh bone, the femur. Now, long bones like the femur, they don't just grow outwards. They lengthen at specific areas of developing cartilage. We call these growth plates, or physes. These physes are transitional zones, sitting between the metaphysis, that's the wider part of the bone shaft next to the growth plate, and the epiphysis, the very end of the bone. And it's the growth plate at the upper end of the femur that's the critical site where this slip occurs. Why there? Well, simply because it's structurally weaker than the mature bone surrounding it. During adolescence, it hasn't fully hardened, hasn't ossified completely. This makes it inherently more vulnerable to giving way under certain mechanical stresses. You can almost think of it as the Achilles heel of the adolescent femur during that period of rapid growth.
That makes perfect sense, a vulnerable zone right at a crucial time of development. Speaking of which, who are the typical patients you see presenting with SCFE? What does the wider epidemiology tell us about prevalence and perhaps any trends we're seeing?
It's quite fascinating, actually, how strongly SCFE correlates with those periods of rapid growth and puberty. For boys, we typically see it hitting between ages 12 and 16. For girls, it's usually a bit earlier, maybe 10 to 14 years old. In terms of how common it is, the prevalence is around 10.8 per 100,000 children. That makes it, without doubt, the most common hip disorder in adolescents. We also see a clear gender difference. It's about 1.5 times more common in boys overall. Though it's worth noting, the really unstable slips, the severe ones, they seem to be at least as common in girls, maybe even more so. When we look at which side is affected, the left hip tends to be involved slightly more often. And bilateral presentation, meaning it affects both hips, that happens in a significant number of cases. The figures vary, maybe 20% up to even 80% in some studies. And when it does happen on the other side, it usually develops within about 18 months of the first slip. This really underlines why we need to keep a close eye on the apparently unaffected hip.
That's a high rate of bilaterality.
It is. And interestingly, recent data suggests we're seeing a rise in incidence at younger ages and also an increasing frequency of these bilateral cases. Many suspect, and I think quite rightly, that this trend is intrinsically linked to the rising rates of childhood obesity that we're seeing globally. It adds another layer to the whole picture.
That link to obesity is stark, isn't it? And certainly something we see across various pediatric conditions, which leads us neatly into the why, the causes, the risk factors, the underlying pathophysiology. We know the exact trigger for SCFE is often unclear, idiopathic, but what are the key contributing factors that clinicians, perhaps especially those in primary care, really need to have on their radar?
You're absolutely right. The precise cause often remains elusive, hence the term idiopathic in many cases. But we have identified several really significant factors that drastically increase a child's risk. The single greatest risk factor by a long way is excessive weight or obesity. Over 80%, think about that, 8 out of 10 patients diagnosed with SCFE are above the 95th percentile for weight. What's truly insightful here is how this pushes SCFE beyond just an orthopedic issue. It becomes a matter of public health, requiring a systemic medical evaluation. That increased body mass just ramps up the mechanical shearing forces across that vulnerable growth plate. It literally puts more stress on it.
So the mechanical load is key. What else?
Beyond the mechanical stress, there's also evidence of a genetic predisposition. Familial cases account for maybe 5 to 7% of affected individuals, suggesting some hereditary component. It's often overlooked, but worth asking about in the history. And crucially, endocrine or metabolic disorders are significant players too. Hypothyroidism is actually the most common non-idiopathic cause. But other conditions, hyperthyroidism, growth hormone deficiency, panhypopituitarism, pseudohypoparathyroidism, even renal osteodystrophy, they can all contribute to weakening that growth plate structure.
So that flags up a really important clinical point then.
Absolutely. Here's a key takeaway. If you see a child presenting with potential SCFE symptoms who is under 10 or prepubertal, or perhaps whose weight is below the 50th percentile, or who has short stature, any of those atypical features, then an endocrine workup is definitely indicated. You need to rule out these underlying systemic issues. For every obese child presenting, we must ask not just about the hip, but about their broader health, their family context, and our role in long-term preventative care. Other less common factors include things like previous radiation therapy near the hip, certain ethnicities seem to have slightly higher rates, and anatomical variations like acetabular or femoral retroversion, which can also increase those shear forces.
That's a really comprehensive overview of the risks, highlighting that multidisciplinary lens we often need. Now let's dig a bit deeper into the pathophysiology. How do these factors actually lead to the slip itself? What is it about the adolescent growth plate that makes it so uniquely susceptible?
Well, the mechanism, fundamentally, it comes down to axial and rotational mechanical forces acting on a growth plate that's already susceptible. The slip itself happens through a specific zone in the physis, the hypertrophic zone. From a microscopic view, this area is weaker. The cartilage cells, the chondrocytes, are less organized. The normal structure breaks down a bit. It becomes the path of least resistance. Now, adolescence is a high-risk period for several specific anatomical reasons. Firstly, there's a structure called the perichondrial ring around the growth plate, which normally gives it some stability. During rapid growth, this ring thins and weakens. Secondly, the growth plate isn't perfectly flat. It has these sort of undulating mammillary processes that normally interlock for stability. During adolescence, these can flatten out or unlock, making it less stable. And thirdly, the orientation of the growth plate itself changes. At birth, it's quite vertical, maybe 160 degrees relative to the shaft. By skill or maturity, it's angled more like 125 degrees. But during adolescence, it's still relatively vertical compared to its final state. This orientation means that forces across the hip are more likely to be shearing forces, trying to slide it sideways, rather than compressive forces pushing down, which the physis is better designed to handle.
Ah, I see. So it's the combination of that weaker zone, the structural changes like the thinning ring and unlocking processes, and that more vertical angle increasing shear stress.
Precisely. So when you apply those increased shear forces, maybe from excess weight, maybe just from normal activity onto a growth plate that's already structurally compromised, whether by disease, genetics, or just the rapid growth itself, well, something has to give. What happens is the metaphysis, the neck and shaft part, translates anteriorly and rotates externally. And the epiphysis, the femoral head, it stays in the socket, but ends up positioned posterior and inferior relative to where the metaphysis has moved. It's very similar mechanistically to Salter-Harris type I fracture through the growth plate, although SCFE often involves a slower, more gradual displacement, particularly in chronic cases. In those chronic slips, the periosteum, the membrane covering the bone, might remain intact and act as a sort of soft tissue restraint, whereas in acute, unstable slips, it might tear, leading to much greater instability.
Right, so that shear failure mechanism is key. Now, for all the clinicians listening, let's move to that crucial clinical picture. What are the symptoms that should really set alarm bells ringing, given that they can be so variable, often quite insidious?
The symptoms do vary considerably depending on whether it's a stable slip, progressing gradually, or an unstable one, happening more suddenly. And this variability is exactly why it gets missed so often. With stable SCFE, the femoral head shifts slowly. So patients typically get intermittent pain. Now, this pain might be felt in the groin or the hip itself, maybe the thigh, or, and this is absolutely critical, just in the knee. It can go on for weeks, even months, and it usually gets worse with activity.
That knee pain point seems really crucial for diagnosis.
It is. The real aha moment for clinicians has to be understanding this. Isolated knee pain in an adolescent is never just knee pain until you've ruled out the hip. It's a massive red flag. You absolutely must do a full hip examination and probably get imaging. Missing this subtle presentation means missing that golden window for the best outcomes in SCFE. This referred pain, it travels down the medial obturator nerve, and it's a notorious mimic. It's present in maybe 15% to as much as 50% of cases, and it's responsible for so many diagnostic delays. Another subtle clue, patients might instinctively sit with the affected leg crossed over the other one. It just feels more comfortable. Something to watch for.
What other signs should we look for?
Other hallmarks. Well, a noticeable limp is very common. Often it develops gradually, gets worse after they've been active for a while. You might see an altered gait pattern. It could be antalgic, meaning they're trying to minimize pain, or waddling gait, or they might walk with the foot turned outwards, an out-toed gait. Sometimes even a Trendelenburg gait, where the pelvis drops on the opposite side when they lift that foot. On examination, the key finding is limited range of motion, especially reduced internal rotation of the hip, and also abduction, moving the leg out to the side. And this brings us to Draymond's sign. This is really important. When you passively flex the patient's hip up towards 90 degrees, the leg will involuntarily rotate outwards. This obligatory external rotation is highly suggestive of SCFE. It's caused by a combination of inflammation of the joint, synovitis, and the displaced front part of the metaphysis impinging on the rim of the socket. In severe cases, or unstable ones, you might even notice the affected leg looks a bit shorter, a leg length discrepancy.
And the unstable cases present differently.
Oh, completely differently. Unstable SCFE is much more acute and dramatic. The key feature is the patient cannot bear weight at all. Even with crutches, they just can't put weight through that leg. There's usually a sudden onset of really intense pain, often after what seems like very minor trauma, maybe just twisting awkwardly or a small fall. And this type carries that much higher risk of serious complications, particularly a vascular necrosis. It needs immediate urgent attention. Early recognition is absolutely paramount.
That paints a very clear picture, especially that warning about knee pain. Okay, so a patient presents, we have these suspicions. What's the definitive diagnostic roadmap from the physical exam through to imaging?
Right, so for diagnosis, first step is a detailed medical history.
Yeah.
You want to know about their general health, growth patterns, how the symptoms started and progressed, any history of minor trauma, any subtle limp noticed by parents. Then the physical examination. With the child lying down, you're specifically assessing hip movements for pain, especially at the extremes of motion. You're looking for that restricted range, particularly internal rotation, feeling for any involuntary muscle guarding or spasm that's the body trying to protect the painful joint. And observing their gait, as we mentioned, is critical. Watch them walk. Look for that limp, the out-toeing. And always, always examine both hips. Even if they only complain of symptoms on one side, you need that comparison.
And then imaging.
Imaging is key. The standard is bilateral hip x-rays. You need both an anteroposterior or AP view and a frog leg lateral view. Getting both hips is crucial for comparison and because of that high rate of bilateral disease. The lateral view, especially the frog leg, is often much better at picking up subtle slips that might look almost normal on the AP view. A word of caution, though. If you strongly suspect an unstable slip where the patient can't weight bear, you should get a cross-table lateral view instead of the frog leg. You want to avoid manipulating the hip, potentially making the slip worse.
What are we looking for on those x-rays?
We're looking for specific signs. The classic one is Klein's line. You draw a line along the superior border of the femoral neck on the AP view. Normally, this line should intersect the lateral part of the epiphysis, the femoral head. In SCFE, because the head is slipped downwards and backwards, the line will intersect less of the head or it might miss it altogether. That's a clear sign of a slip. On the frog leg lateral view, you can look for the S sign. You trace the smooth curve along the inferior edge of the femoral neck and head. In SCFE, this smooth S shape is disrupted. You'll see a sharp turn or a break in continuity where the slip has occurred. Using both Klein's line and the S sign together really boosts diagnostic accuracy. Other, sometimes earlier, signs include epiphysiolysis, which just means the growth plate itself looks wider or more lucent than the other side. And the metaphysio blanch sign of steel, seen on the AP view, it's a sort of blurring or increased density of the metaphysis because it's overlapping with the posteriorly displaced epiphysis.
And what if the x-rays are inconclusive, but you still suspect it?
Good question. If x-rays are negative or maybe equivocal, but your clinical suspicion is still high, then advanced imaging like MRI can be incredibly helpful. MRI can actually diagnose pre-slip conditions. It might show widening of the growth plate or edema, swelling in the metaphysis that shows up as decreased signal on T1 images and increased signal on T2 images. CT scans aren't usually needed for initial diagnosis, but they can be useful sometimes for really precise surgical planning, especially if complex reconstruction is being considered. They give you that detailed 3D picture of the deformity. And don't forget those lab tests we mentioned. If the patient is atypical under 10, prepubertal, low weight, short stature, you need to check things like TSH and free T4 for thyroid issues, or BUN and creatinine for kidney problems. It's about that comprehensive approach, making sure you don't miss an underlying cause.
That's a very thorough diagnostic pathway. Before we jump into treatment quickly, what are some key differential diagnoses? What else could present like SCFE that clinicians need to keep in mind?
Yes, the differential is important. What else could this be? Top of the list, especially with acute pain and inability to weight bear, is septic arthritis, a true orthopedic emergency needing urgent drainage. Then there's transient synovitis, sometimes called irritable hip, which is common but usually resolved quickly. Osteomyelitis, a bone infection, needs consideration. In slightly younger children, Legg-Calvé-Perthes disease affecting the blood supply to the femoral head is a key differential. Developmental dysplasia of the hip can sometimes present later with pain or a limp. Of course, various traumatic injuries, things like avulsion fractures where a tendon pulls off a piece of bone, or simple muscle strains around the hip or pelvis. But here's the clinical pearl. Slipped capital femoral epiphysis should always be on your list. In any adolescent presenting with hip, thigh, or crucially knee pain, especially if there's a limp, even if there's no history of significant trauma, the consequences of missing it are just too severe. A misdiagnosis leads directly to worse outcomes. So even if you think it's something simpler, you have to actively rule out SCFE first.
Absolutely. Always keep SCFE high on that list, especially with those critical time pressures for intervention. Okay, so diagnosis confirmed. How do we then classify the severity? What are the different systems used, and what do they tell us about prognosis and likely long-term outcomes?
Classification is vital. It's not just for labeling. It guides treatment and helps predict the future. The most important system, prognostically, is the Loader classification. It's simple, based purely on the patient's ability to bear weight. A stable SCFE means the patient can walk on the affected leg, maybe with crutches, maybe without. This is the most common type, about 90% of cases. And crucially, the risk of osteonecrosis, that devastating loss of blood supply, is relatively low, typically under 10%. By contrast, an unstable SCFE means the patient absolutely cannot bear weight on that leg, even with crutches. This is far more serious. The risk of osteonecrosis here jumps dramatically, anywhere from 24% up to 47%. This distinction is critical. Unstable SCFE is an urgent situation.
So stable versus unstable is the key prognostic divide. Are there other ways to classify it?
Yes, there are others, though perhaps less used for prognosis now. There's the temporal classification, based on how long symptoms have been present. Acute is less than 3 weeks, chronic is more than 3 weeks, and acute on chronic is when someone with long-standing symptoms has a sudden worsening. Then there's the Southwick slip angle classification. This measures the actual degree of slip radiographically, comparing the angle of the epiphysis to the shaft on the lateral X-ray. It classifies slips as mild, less than 30 degrees difference, moderate, 30 to 50 degrees, or severe, over 50 degrees. And finally, there's a simple grading system based on the percentage of the femoral head's width that has slipped posteriorly on the lateral view. Grade first is 0.33%, grade 2 is 34.50%, and grade 3 is over 50%. But the key insight, the one that really drives immediate management decisions and predicts the risk of major complications, is Loader's stable versus unstable classification based on weight-bearing ability.
Okay, that's very clear. So focusing on prognosis, what factors ultimately have the biggest influence on the long-term outlook for these young patients? Why is getting that diagnosis quickly so absolutely vital?
The long-term outlook really hinges on two main things. Firstly, the initial severity of the slip, how far it slipped before treatment, and secondly, and this is crucial, how quickly it was recognized and treated. Early diagnosis makes a massive difference. It significantly cuts down the risk of complications and leads to much better long-term hip function. The evidence is really stark here. For those unstable slips, if surgery happens within 24 hours of symptoms starting, the rate of vascular necrosis, or AVN, is around 7%. But if that surgery gets delayed beyond 24, maybe 48 hours, the AVN rate skyrockets. You can be as high as 87.5%. That's a catastrophic difference, purely down to timing. It makes timely diagnosis almost a matter of salvaging the hip.
That's an incredible difference just based on timing.
It really is. Now, patients with milder stable slips generally do have better outcomes overall. But, and this is important, even mild cases unfortunately carry an increased risk of developing premature osteoarthritis later in life. So, early diagnosis and intervention aren't just important, they are genuinely life-altering for these young people. It impacts their ability to be active, their quality of life for decades, and their potential need for major hip surgeries like hip replacements much earlier than they should. Beyond just the AVN risk, a delayed diagnosis often means a more significant deformity develops. This can lead to earlier problems with femoroacetabular impingement, or FAI, causing chronic pain, and ultimately accelerating that path toward degenerative arthritis.
Those statistics really hammer home the need for immediate action. Okay, let's turn to treatment then. Once SCFE is diagnosed and classified, what are the main goals and what's the standard approach?
The primary goals of treatment are really quite straightforward, conceptually at least. First, stop the femoral head from slipping any further. Arrest the progression of the deformity. Second, stabilize the hip joint in its current or an improved position. And it's vital to stress, management is almost exclusively operative. Surgery is required. As soon as you even suspect SCFE, that patient must be made strictly non-weight-bearing on the affected leg. Immediately. No ifs, no buts. Hospital admission is usually necessary, and surgery is typically scheduled promptly, often within 24 to 48 hours, especially if it's an unstable slip. That immediate non-weight bearing is just as critical as the surgery itself to prevent making the slip worse.
Right, so immediate non-weight bearing urgent surgery. Let's talk about the most common procedure you mentioned, in situ fixation. How is that actually done, and what are the crucial technical details for success?
In situ fixation with percutaneous screws is definitely the workhorse procedure. It's used most often, especially for stable slips or mild to moderate ones. And it's done minimally invasively, which is a big advantage. The technique involves making just a small incision, usually on the side of the upper thigh. Then, under X-ray guidance, we insert a metal screw across the growth plate. The screw goes from the femoral neck, across the physis, and into the epiphysis, effectively pinning the ball onto the cone to stop it slipping further. The aim is to hold it steady while the growth plate naturally fuses over time. Usually, a single, large, cannulated screw is sufficient. Using just one screw is generally preferred, as it's thought to carry a slightly lower risk of damaging the blood supply compared to using multiple screws. Although in some cases, 2 screws might be used for potentially greater biomechanical stability.
And the placement of that screw is critical.
Absolutely critical. The screw needs to be positioned perfectly. Ideally, it should be perpendicular to the growth plate itself and bang in the center of the femoral head when you look at it on both the AP and the lateral X-ray views. The starting point on the femur is usually anterior, and it's vital, absolutely vital, to avoid placing the screw too far medially, too close to the inside edge of the neck, near the lesser trochanter. If the screw head sits proud medially, it can impinge against the acetabular rim during hip flexion, causing pain and limiting movement down the line. The screw needs to be advanced carefully until its tip is about 5 millimeters away from the joint surface, the subchondral bone. And you need to ensure you get good purchase in the epiphysis. Ideally, at least 5 threads of the screw should be securely biting into the epiphysis. If you have fewer than 5 threads engaged, the risk of the slip progressing despite the screw is significantly higher. That's a major concern. We use fluoroscopy live X-ray imaging throughout the procedure to guide placement. And we use a technique called the approach-withdraw technique, gently advancing and withdrawing the guide wire to be absolutely certain we haven't inadvertently poked through into the joint space, which could cause serious cartilage damage or chondrolysis.
And recovery after that.
Postoperatively, patients with stable slips that were fixed can often start bearing weight fairly quickly, as tolerated. But for unstable slips that have been fixed, they typically need a period of touchdown weight bearing only, usually for about 6 weeks, to allow the soft tissues to heal and the fixation to become secure.
That's a very clear picture of the standard approach. Now, what about those more difficult situations? Unstable slips, severe slips, or maybe chronic deformities that have already set in? What other surgical options are on the table?
Yes. For the more challenging cases, unstable slips, severe slips with significant displacement, or chronic slips that are already causing symptoms due to the altered shape, more extensive procedures might be needed. One option is open reduction. This involves making a larger surgical incision, carefully exposing the hip joint, and then gently manipulating the femoral head back into a more anatomical position before fixing it, usually with 1 or 2 screws. It's obviously a bigger operation than pinning it in situ, carries higher risks, particularly to the blood supply, and involves a longer recovery. Then there's the modified Dunn procedure. This is a more complex technique aimed at achieving an accurate anatomical reduction, particularly for severe unstable slips, while making very specific efforts to preserve the delicate blood supply to the femoral head. It typically involves a surgical hip dislocation, using techniques like the Gans approach with a trochanteric flip osteotomy to safely access the joint without damaging vessels. The surgeon then carefully cleans up the metaphyseal surface before reducing the epiphyses and fixing it, often with temporary K-wires or definitive screws. However, this is a highly demanding procedure. It has a steep learning curve, and it does carry a higher complication rate. Reported AVN rates are around 26%, maybe higher, and the overall complication rate can be up to 37%. So it remains somewhat controversial, usually reserved for specific cases where the potential benefit of restoring normal anatomy is thought to outweigh those significant risks.
And what about correcting deformities that have already developed?
Right. For severe chronic SEFE, where the slip angle is made more than 30 or 45 degrees, and the patient has symptoms, usually pain or limited function due to impingement, we might consider a proximal femoral osteotomy. This basically means cutting the bone somewhere below the slip and realigning the femur to correct the deformity and improve the hip's mechanics. Common types are the introchanteric osteotomy, also called the Imhauser osteotomy, that's probably the most frequently used, or the subtrochanteric osteotomy, the Southwick. There's also a femoral neck cuneiform osteotomy, which can achieve a large correction right at the site of the deformity. But historically, it's had very high rates of AVN and arthritis, so it's used very cautiously, if at all. The main goal of these osteotomies is to prevent or treat femoroacetabular impingement, FAI, reduce pain, improve function, and hopefully delay the onset of degenerative arthritis in the long run. Choosing the right procedure involves carefully balancing the amount of correction needed against the surgical risks and complexity.
That certainly covers the surgical spectrum. Thinking proactively again, what about the other hip? Given that high rate of bilateral involvement, is there a role for preventative surgery on the contralateral side?
Yes, that's a really important question. And the topic of prophylactic in situ fixation in the opposite hip is definitely discussed widely, though it remains somewhat controversial. The idea is to preventively pin the apparently normal hip in patients deemed to be at particularly high risk of developing a slip on that side later on. So who falls into that high-risk category? Well, factors include having the initial slip at a very young age, say under 10, having open triradiate cartilage in the pelvis, which indicates significant remaining growth potential. Being an obese male is a known risk factor. And having one of those underlying endocrine disorders we talked about, which weakens the growth plate systemically. The decision involves carefully weighing the small but real risks of surgery on a currently normal hip against the significant chance of developing a second slip, which could potentially be unstable and carry that high AVN risk. It's also worth noting, interestingly, that achieving weight loss after the surgery for the first slip seems to be associated with a lower risk of developing SCFE on the other side. This really highlights managing obesity postoperatively as a potentially crucial preventative strategy in itself.
And thinking even further down the line, after the initial fixation, what about managing long-term consequences? Are there other procedures to address issues like impingement that might develop later on?
Indeed. The initial fixation deals with the acute problem, stopping the slip, but it doesn't always prevent long-term mechanical issues resulting from the residual deformity. For patients who develop symptomatic femoroacetabular impingement, or FAI, because of that residual bump on the femoral neck, the cam lesion, which can happen even after mild or moderate slips have been stabilized, we can perform an osteochondroplasty. This procedure involves surgically reshaping or trimming that bony bump at the head-neck junction. The goal is to restore smoother movement, eliminate the painful impingement against the acetabular rim, and hopefully prevent further cartilage damage. This can often be done arthroscopically, using keyhole surgery, or sometimes via a small open incision, a limited anterior arthrotomy. In more complex cases, a surgical hip dislocation might be needed to get adequate access to reshape the bone properly. It's really about proactively managing the hip's mechanics for the long term, trying to preserve the native joint and delay or prevent the progression to osteoarthritis.
It's clear the initial surgery is often just the start. Let's talk about the potential pitfalls. What are the major complications associated with SCFE, both from the condition itself and potentially from the treatment? How do we watch out for them?
Yes, the potential complications are significant, and they can cast a long shadow over a patient's life, sometimes for decades. The most feared complication is definitely a vascular necrosis, AVN, or osteonecrosis. This is when the blood supply to the femoral head gets disrupted. The bone tissue dies, collapses, leading to severe pain and arthritis. As we said, the single biggest predictor is having an unstable SCFE. The incidence there is tragically high, 24% to 47%, but it can also happen after surgery in maybe 4 to 6% of cases, especially if fixation hardware damages vessels in that critical posterior-superior region of the femoral neck. And a really worrying thing about AVN is that the early signs might not show up on x-rays for a long time, maybe 12 to 18 months post-event. So you need that diligent long-term radiographic follow-up. It's often a silent process initially until collapse occurs.
What else should we be concerned about?
Another serious, though thankfully rarer complication is chondrolysis. This is a rapid and severe destruction of the articular cartilage, the smooth lining of the hip joint. It causes intense pain, stiffness, deformity, and often permanent loss of hip mobility. The exact cause isn't always clear, but it's thought to involve severe inflammation or sometimes critically unrecognized penetration of the joint surface by a screw or pin, especially in the anterosuperior part of the head. CT scans are often better than x-rays at picking up subtle metalwork penetration if chondrolysis is suspected. Impingement, FAI, is another common issue, as we just discussed. It can arise from the residual shape change of the femur after the slip, that pistol grip deformity you might see on x-ray, or sometimes from the placement of the fixation screw itself, leading to pain and restricted movement. We also sometimes see slip progression, even after fixation. It's reported in maybe 1% to 2% of cases after single screw fixation, particularly if you didn't get enough threads, fewer than 5, securely into the epiphysis. It highlights the importance of meticulous surgical technique.
And the consequences of delay.
Yes, the impact of delayed diagnosis is itself a major complication. It's strongly linked to a more severe slip by the time treatment starts, and therefore a worse long-term prognosis, especially when that misleading knee or thigh pain is the only initial symptom. Long-term, patients face the risk of chronic pain and early degenerative arthritis. Studies suggest around 45% of SCFE patients might eventually need a total hip replacement within 50 years of the initial injury. Even those with initially mild slips are at higher risk of developing osteoarthritis at a younger age than their peers. And let's not forget the development of SCFE in the contralateral hip. As we mentioned, this is actually one of the most common complications after fixing the first side, with rates anywhere from 20% to 80% requiring ongoing vigilance. Finally, though less common with modern fixation techniques, premature closure of the growth plate can occasionally lead to femoral growth arrest and limb length discrepancy.
That is a rather comprehensive and quite sobering list of challenges. It really underscores why this condition needs such careful, long-term management. So given all that, what does the post-operative journey look like? Thinking particularly about rehabilitation, follow-up care, how do we guide these patients back to function like that young athlete we imagined at the start?
The postoperative journey is absolutely critical. Getting this phase right is essential for maximizing recovery and minimizing those long-term problems. Firstly, weight bearing. Patients and their families need clear instructions and must adhere to them strictly. Usually they'll be on crutches for several weeks. The surgeon gives specific guidance on when it's safe to start putting more weight through the leg, progressing eventually to full weight bearing. And remember, non-weight bearing is vital right from the moment of diagnosis until after surgical stabilization. Secondly, physical therapy. This is non-negotiable, really. A physiotherapist experienced in post-op hip rehab is essential. They'll create a tailored exercise program. The focus initially is on reducing pain and inflammation, protecting the surgical site, and gentle range of motion exercises. Then, as healing progresses, they work on weaning off crutches once the patient has a pain-free gait and good muscular control. Later phases ramp up strengthening exercises for the hip and leg muscles, improve range of motion further, work on aerobic conditioning, and importantly, retrain functional movement patterns needed for daily life and sport. The final phase ensures they have adequate strength and control for a safe return to their desired activities. It's usually a structured, multi-phase approach, often spanning several months.
What about getting back to sport?
Yes, sports and strenuous activities. There will be temporary restrictions. It's crucial to avoid overloading the hip too early. which could lead to complications or re-injury. The surgeon and physio will guide the patients when it's safe to gradually reintroduce activities, which can often be a frustrating period for an active teenager, requiring careful management of expectations. And finally, follow-up care. This needs to be consistent and long-term. Regular appointments are usually needed for at least 18 to 24 months after surgery. These visits typically include repeat x-rays, maybe every 3 to 4 months initially, then less frequently. We're monitoring for growth plate closure, checking the position of the hardware, and crucially, looking for any early signs of complications like AVN or chondrolysis. And often, as we've touched upon, a multidisciplinary approach is best. Liaising with pediatricians, endocrinologists if there's an underlying disorder, perhaps dietitians for weight management. This coordinated care ensures we're managing the whole patient, not just the hip, which ultimately leads to better overall outcomes.
That comprehensive follow-up is clearly vital for catching any long-term issues early. Now, shifting perspective slightly towards the proactive side, how might SCFE potentially be prevented? What role do those modifiable risk factors play in a broader public health sense?
Prevention strategies for SCFE really center on addressing those modifiable risk factors we identified. And top of that list, unquestionably, is weight management. This is absolutely paramount. Given that over 80% of children who develop SCFE are classified as obese, often with a BMI above the 95th percentile, tackling childhood obesity is probably the single most effective preventative measure we have. Healthcare providers need to counsel parents, caregivers, and the children themselves on developing and sticking to safe, sustainable diet and exercise plans. Helping children achieve and maintain a healthy weight is key. Regular physical activity is part of that. It not only helps with weight, but also strengthens the muscles around the hips, potentially providing better dynamic stability. Guidelines like those from the American Academy of Pediatrics recommend at least an hour of moderate to vigorous activity daily for adolescents. For our hypothetical young athlete, achieving a healthier weight might be just as important as the surgery in preventing a slip on the other side.
Beyond weight, what else?
Increased awareness and screening are also crucial. Clinicians, particularly in primary care and emergency departments, need to maintain that high index of suspicion. Always include SCFE in the differential for any preteen or teen with hip, groin, thigh, or especially that misleading knee pain. Actively screening for risk factors might be advisable, especially for children presenting outside the typical age range or those with unusual height or weight percentiles, just asking the right questions. And finally, promoting broader lifestyle modifications. It's not just about weight. Encouraging regular physical activity in general, avoiding prolonged sedentary periods, maybe incorporating activities that promote hip range of motion and strength, also ensuring adequate intake of nutrients important for bone health during those rapid growth spurts, things like calcium and vitamin D. By proactively addressing these factors, we might significantly reduce the incidence of SCFE and its subsequent burden, shifting towards a more preventative approach.
That proactive, holistic view makes complete sense, especially given the potential long-term impact. And just to bring this all together, Professor, how critical is that coordinated care approach you mentioned? What does effective interprofessional communication really look like when managing SCFE to ensure the best possible patient outcomes?
It's absolutely fundamental. A coordinated care approach isn't just helpful. It's essential for achieving the best outcomes in SCFE. Effective communication between everyone involved, the pediatrician or GP, the orthopedic surgeon, the radiologist interpreting the images, the nurses on the ward and in clinic, the physical therapist guiding rehabilitation, maybe an endocrinologist or a dietitian if needed, is paramount. It's not just about each person doing their job well. It's about how seamlessly that information flows and how well care is integrated. The optimal pathway relies on several key steps working together. Early recognition of symptoms, often by the first clinician the patient sees, immediate implementation of non-weight bearing, prompt referral and consultation with an orthopedic surgeon, timely and appropriate surgical management, and then that comprehensive long-term follow-up. Each member of the team plays a vital role. The primary care clinician's vigilance can prevent further slipping. The radiologist's accurate read guides the surgeon. The surgeon's skill stabilizes the hip. The physio's expertise restores function. It's this collaborative effort, underpinned by open, clear, and timely communication, that truly optimizes results and minimizes the long-term impact of SCFE on a young person's life. It's really about shared responsibility for that patient's future hip health.
Professor Imam, this has been an incredibly insightful and thorough deep dive into slipped capital femoral epiphysis. You've certainly reinforced the profound importance of vigilance, timely diagnosis, and that comprehensive multidisciplinary management for securing the best possible long-term outcomes for these young patients, truly safeguarding their future mobility.
It's been my pleasure. Perhaps a final thought for our colleagues listening is this. Considering the potentially lifelong impact SCFE can have on hip function and quality of life, really understanding the nuances of early intervention, the subtleties of diagnosis, and the evolving landscape of hip preservation techniques for these children isn't just academic interest. It feels more like a moral imperative. Our collective awareness and timely actions can genuinely protect the future activity and well-being of these young individuals, helping them avoid decades of potential pain and disability.
A very powerful thought to end on. Thank you. If you found this deep dive valuable, please do consider leaving us a rating and sharing it with your professional network. Our sincere thanks again to Professor Mulimam for his exceptional insights today. We look forward to delving deeper into another critical topic with you next time on The Deep Dive.